Pones, Rhizins, and Bad Blood, a Malignant Hematology Primer. So, those of you that aren't from rural areas may not be familiar with the terms Pones, Rhizins, and Bad Blood, but those are frequently used to describe swollen lymph nodes, abscesses, and just bad blood. So what are the hematologic malignancies? They're acute and chronic leukemias, lymphomas that consist of Hodgkin's lymphoma and the cleverly named non-Hodgkin's lymphoma, multiple myeloma, and myelodysplastic syndromes. Myelodysplastic syndromes will not be covered extensively today, but let me say a few brief comments about them. They used to be known as pre-leukemia. Not all of them do evolve into a leukemia, so that term has fallen out of favor. However, they're still considered a malignancy. They generally occur in older people. Frequently they occur after the administration of chemotherapy for other malignancies that end up damaging the bone marrow. Myelodysplastic syndromes can evolve into leukemias that have a particularly bad prognosis. Fortunately, hematologic malignancies are not especially frequent. Their incidence per 100,000 is demonstrated on this slide, with an overall incidence of 6 to 10 cases per 100,000 people. CLL, or chronic lymphocytic leukemia, and acute myelogenous leukemia, or AML, are the most common, but you can see from this that all are in the 1 to 3 people per 100,000. When we look at this at a slightly different perspective, the estimated U.S. cancer cases, we see that in men, non-Hodgkin's lymphoma comprises only 5% of the malignancies, in leukemia 3% of the malignancies. In women, leukemia doesn't even make the top hit parade, and only 4% of the malignancies in women are non-Hodgkin's lymphoma. Continuing the theme of the health impact of hematologic malignancies, this is the estimated cancer deaths caused by different malignancies. You see that now leukemia in men has jumped up to 4% of the deaths, and it does now appear at 3% of the deaths in women. This slide represents the maturation pathway of white blood cells in both myeloid and lymphoid. It should be noted that most of the malignancies that we're going to speak about are in the upper row here with ALL and the B-cell malignancies of CLL, non-Hodgkin's lymphoma, and multiple myeloma. T lymphocytes are here, but they are much less frequent in malignancies. The myeloid progenitors are in the second row, seen in red, AML or chronic myelogenous leukemia, and those are the myeloid malignancies. This slide gives some of the same information as the previous slide, but it gives you some anatomical landmarks to show where maturation takes place. Within the stem cell within the bone marrow moves to the lymphoid progenitor, and then it becomes a pre-B cell, and pre-B cells have a malignant potential of going into acute lymphoblastic leukemia. Maturation can otherwise continue normally from the immature B cell leaving the bone marrow space and finding its way into lymphoid tissue. Within the lymphoid tissue, we have mature but naive B cells that can transform into chronic lymphocytic leukemia, or the mature naive B cell can mature into a germinal cell B cell, which can then, in bad cases, become a malignancy called diffuse large B-cell lymphoma, follicular lymphoma, or Hodgkin's lymphoma. If normal maturation continues, these become plasma cells, which are still a B cell. but a malignant plasma cell is multiple myeloma. You've seen this slide before, but I put it in here to remind you that now we're talking about chronic lymphocytic leukemia, and it arises out of the naive B lymphocyte. What follows is a discussion of chronic lymphocytic leukemia. This is a peripheral blood smear of a patient with chronic lymphocytic leukemia. You see he has normal red cells, normal platelets, and then these mature appearing lymphocytes, but there are way too many of them, reflecting the lymphocytosis that is diagnostic for CLL. So what causes chronic lymphocytic leukemia? It doesn't appear to be related to radiation exposure or to alkylating agents. Alkylating agents are usually chemotherapy agents used to treat other malignancies. There does seem to be an increased risk in families of the magnitude of 2 to 7 times normal. It may be related to herbicides. There's been some epidemiologic studies that show that that might be the case. These epidemiologic studies were done in agricultural settings. And there's been some evidence that viruses such as the human T lymphocyte virus 1 and 2 and the Epstein-Barr virus may be implicated in the cause of CLL. But in general, there's no clear etiology for CLL. So what kind of presentation do patients have that have CLL? Well, 25% of them will not be symptomatic at all, and this will be picked up on a routine CBC done for other purposes. 87% of them, however, will have lymphadenopathy that's palpable that they will probably notice before their physicians do. Half of them will have splenomegaly that may or may not be symptomatic, and only a minority, 14%, will have hepatomegaly, also usually asymptomatic. On the laboratory presentation, the white count will be over 100,000 in about a third of the patients. About a third of the patients will be anemic with a hemoglobin of less than 11 grams per deciliter, and a minority at 16% will have platelet counts of less than 100,000. So generally it's a patient that has some palpable lymphadenopathy, an elevated white count, and maybe a mild anemia, and perhaps a low platelet count. Not everybody that has an elevated white count or lymphocyte count has chronic lymphocytic leukemia, as there are other causes such as mononucleosis, pertussis, or toxoplasmosis. The National Cancer Institute has formulated diagnostic criteria that are seen on this slide, meaning that they have to have an absolute lymphocyte count of over 5,000. An absolute lymphocyte count is calculated by taking the percentage of lymphocytes seen in a peripheral smear and multiplying that by the total white count. Also, these lymphocytes have to be monoclonal and mark with CD5, CD19, CD20, and CD23. These markers are determined by using a technique called flow cytometry. There also will be low levels of surface immunoglobulins on the malignant cells, and when a bone marrow exam is done, at least 30% of the cells need to be lymphocytes. As with other malignancies, CLL has a staging system. The purpose of staging systems is to determine tumor bulk, which helps determine the prognosis of the patient, and in some cases helps determine treatment. There are two major staging classifications for CLL. The one is the Rye classification, which is on this slide, and the Binet classification, which will be on the next slide. On this slide, you see the survival column. This was survival essentially untreated, as published in 1975. This has changed with recent therapies. The stage 0 is just a lymphocytosis. They would have a greater than 5,000 absolute lymphocyte count and not have any lymphadenopathy, hepatomegaly, anemia, or thrombocytopenia. The presence of any of those advances the stage, with adenopathy moving the stage to 1, hepatomegaly or splenomegaly moves it to 2, the development of an anemia moves it to 3, and lymphocytopenia of less than 100,000 or thrombocytopenia of less than 100,000 moves it to a stage 4. You can see that the survival with the Rye classification is linked to its stage. The Binet classification is seen on this slide, and what has happened is that the Binet classification collapses the 0 through 4 stage of the Rye classification into A, B, and C, since the survival of some of the subgroups on Rye were very similar. It still uses lymphocytosis and lymphadenopathy, as well as the development of anemia or thrombocytopenia to determine the stage. CLL is really a malignancy of our immune system. So because of that, you can expect some immune complications with CLL. They may have a hemolytic anemia or a thrombocytopenia that is determined by aberrant immune responses in the malignant cells. Also, because some of their immune system is now malignant, these patients will get an increased risk of infections. Interestingly, the presence of autoimmune hemolytic anemia and immune thrombocytopenia do not advance the stage of CLL. If the thrombocytopenia or anemia is because of an immune response, that can be treated, and the stage would be whatever it would be without the anemia or thrombocytopenia. I put this slide in here to clarify one of what we'd have to call, instead of an old wives' tale, an old doctor's tale, and that is that CLL is an indolent disease associated with a 10 to 20-year clinical course with death unrelated to CLL. This is only true less than 30% of the time. Even in the era of effective therapy, most people with CLL are fated to die of this malignancy or complications of it. There are features that will make CLL's prognosis better. The first we've already talked about, the clinical stage. The next would be, how does the bone marrow appear under the microscope, whether it's interstitial infiltration with lymphocytes or if it's a nodular pattern. Next would be, is the lymphocyte doubling time greater than 12 months, as measured just by a complete blood count. And flow cytometry shows CD38 to be negative on the cells. This is good prognosis. And counterintuitively, if there's mutations of the immunoglobulin gene, this is actually a good thing and causes a better prognosis. The ZAP70 is an indirect measurement of the mutated immunoglobulin gene, but if it is negative, it also means that there's a good prognosis. There are particular chromosomal abnormalities sometimes found with CLL, and one of them is a mutated 13q14 chromosome. And that is also a good thing in CLL. The principles of therapy in CLL are somewhat different than the treatment of most other malignancies, and that there is a lack of evidence that early therapy affects long-term survival. This is in marked contrast to, say, breast cancer, where early detection clearly has an impact upon survival. There is a lack of evidence that CLL is curable even with the modern therapy, but it is very treatable. And treatment initiation and its cessation are primarily symptom-driven. As I said previously, there's no evidence that the early treatment of CLL makes it more curable, and so we're just going to initiate treatment on the basis of symptoms. These are some of the symptoms that would call our hand in starting therapy: the development of fevers, night sweats, unexplained weight loss, a progressive anemia, thrombocytopenia that becomes symptomatic with some bleeding, progressive or painful splenomegaly, progressive or bulky lymphadenopathy. This could be just a cosmetic problem, such as swollen nodes in the neck or under the jaw, which are cosmetically unacceptable, or if there's a rapidly increasing lymphocytosis, such as the previously mentioned fast doubling time of lymphocytes, and if there are autoimmune cytopenias, either thrombocytopenia or anemia. This is a list of the available treatments for CLL. At the top of the list is the watch and wait approach. Symptoms dictate the initiation of treatment. There are many patients that have a stage 0 or stage A CLL that could watch and wait for many years, some essentially until they die of something else, and never require treatment. If treatment is required, we have the old-style alkylating agents, chlorambucil and cyclophosphamide. Prednisone can be used, especially if there's a presence of one of the thrombocytopenias that's immune-mediated. Fludarabine is a chemotherapy agent. Alemtuzumab or Campath is also sometimes used. Some of the newer treatments are monoclonal antibodies that are directed against the CD20 molecule found on CLL. And the newest thing is ibrutinib, which is a bruton kinase inhibitor that is very effective in CLL, and it's a pill, so it has relatively few side effects. The only curative therapy available for CLL is an allogeneic stem cell transplant. Let's move to another one of the chronic leukemias, the chronic myelogenous leukemia. I've inserted this slide again to keep you oriented as to what cell line we are discussing. We've now moved down to the myeloid progenitors for chronic myelogenous leukemia. This slide compares the peripheral blood smear of a normal person to that of a person with chronic phase chronic myelogenous leukemia. On the normal slide, you'll see polymorphic neutrophils. On the chronic phase CML side, you'll see similar cells, polymorphic neutrophils, but you'll also see some cells that have large nuclei, and these are immature white cells. They are not necessarily blasts, as blasts do not predominate with this particular type of leukemia. However, the peripheral blood in chronic myelogenous leukemia does have immature cells, making it appear very similar to the bone marrow of a normal patient. It's just that the cells are now in the peripheral blood rather than stuck in the bone marrow. CML occurs in relatively young people compared to other hematologic malignancies, with the median age at presentation in middle age 45 to 55 years of age. However, the incidence does increase with age, with 12 to 30% of the patients being over 60 years old. There does seem to be a slight male predominance to female of 1.3 to 1, and 50% of patients are diagnosed with routine laboratory tests that were obtained for another reason. And 85% of the patients are diagnosed during the chronic phase. We'll talk about the different phases of CML in a few slides. The symptoms of CML are pretty nonspecific. In fact, half of the cases are just, as I previously mentioned, diagnosed on the basis of an abnormal CBC obtained for some other reason. When patients do have symptoms, they are nonspecific, such as fatigue, loss of appetite or weight loss. Perhaps they'll have abdominal fullness, which reflects the splenomegaly. Some patients will have palpable splenomegaly, but usually not. On laboratory, they'll have an abnormal differential with the immature white blood cell forms seen as noted on the previous slide. There may be a leukocytosis, maybe a thrombocytosis, There may be an anemia and a basophilia. As I mentioned before, there are 3 different phases of chronic myelogenous leukemia. This is similar to staging in solid malignancies, in that there's the chronic phase, accelerated phase, and a blast crisis. These are determined by the presence of different sorts of white cells in the peripheral smear. The white count has to be over 20,000 to make the diagnosis. If the blast count is greater than 15%, but less than 30%, it's accelerated phase, and if it's greater than 30%, it's a blast crisis. Basophils are increased in all phases, but if they're greater than 20%, they're accelerated phase. Platelets can be either low or high and really don't determine the phase. The bone marrow exam will always show a myeloid hyperplasia. Again, this doesn't affect the phase. All patients with CML will have abnormal cytogenetics with what's called the Philadelphia chromosome, which is a translocation of chromosomes 9 and 22, and BCR-ABL will be positive, which is a molecular test that really is looking for a Philadelphia chromosome in a different way. This slide makes the point that the different phases of CML do have an impact upon survival. This slide is really derived from the era of the pre-tyrosine kinase inhibitor, which we'll talk about later. But the chronic phase used to last a median of 5 to 6 years. The accelerated phase then occurred, which lasted from 6 to 9 months. And blast crisis, unfortunately, had a very poor prognosis with a median survival of 3 to 6 months. CML is unique among the hematologic malignancy in that it's a disease linked to a single molecular abnormality, and that is the presence of a Philadelphia chromosome, again, the translocation between 9 and 22 chromosomes. It has a well-characterized clinical course, as previously seen in the slide, of chronic phase, accelerated phase, and a blast crisis. While it is thought the Philadelphia chromosome is the single cause of CML, the Philadelphia chromosome can also occur in other hematologic malignancies. In CML, as I mentioned, it's in greater than 95% of the patients, and actually using molecular methods, it's 100% of the CML patients have this abnormality. However, it can also occur in adult acute lymphoblastic leukemia up to a third of the time, and in pediatric acute lymphoblastic leukemia about 5% of the time. It is rare, but it still seen presence in acute myelogenous leukemia in adults, about 2% of the time. BCR-ABL, mentioned in this slide, is used interchangeably with the translocation of 922 seen in the Philadelphia chromosome. Since this is the causative abnormality in CML, it has allowed the development of drugs that will inhibit the tyrosine kinase activity. BCR-ABL tyrosine kinase is constitutively activated intracellularly and allows unhampered proliferation of immature myeloid cells, which is CML. So if we can inhibit the tyrosine kinase activity, CML can be arrested. The drug that was developed that did this was imatinib, and known as Gleevec. There's now several agents that inhibit tyrosine kinase activity, but imatinib is the grandfather of all of them. It has revolutionized the treatment of this disease and has made it potentially curable over the course of several years. Let's now turn our attention from the chronic leukemias to the acute leukemias. We'll again use this slide to keep you oriented as to where we are in the development of white cells and the development of these malignancies. Acute lymphoblastic leukemia is seen on the top through the lymphoid chain. Notice that it's very early in the maturation of lymphoid cells. When we drop down to the next row, we see AML, which again is early in the development of white blood cells. If you look over to the right and see neutrophils, eosinophils, etc., each one of those could have their own subtype of leukemia. This is the peripheral smear of a patient with acute myelogenous leukemia. And when you see the dark purple nucleus, you'll notice a rod coming up. That's called an Auer rod, which, while it does not occur in all AML, when it does occur, it makes the diagnosis fairly easy. In this slide, I've mixed the epidemiology, etiology of acute myeloid leukemias and acute lymphoblastic leukemias to help compare and contrast them. The total incidence of these, as previously mentioned, is not especially common, with only 4 per 100,000. 25% of the acute leukemias will occur in children, however. 90% of adult leukemia is acute myeloid leukemia, where 80% of childhood leukemias are acute lymphoblastic leukemia. ALL incidence decreases after age 9. AML incidences increases with age, with 30% of the patients occurring after age 60. Unfortunately, progress in treating patients with AML over the age of 60 has lagged behind progress in treating younger patients with AML. Males are more likely to get AML as an infant or if in the elderly. The increased incidence of AML in males is interesting in that it probably has to do with the lack of a second X chromosome, but that's a topic for a different sort of lecture. This is the age-specific incidence rates for acute myelogenous leukemia in all races seen around the turn of this century. It really hasn't changed much since that time. You'll see that it is an uncommon disease before the age of 60, but has a sharp increase in incidence starting around the age of 60. As previously mentioned, this has implications in the curability of the disease in that the older patients have a much worse prognosis than young patients. While there are some things that seem to increase the risk of developing AML, it's safe to say that most patients that develop AML do not have any of these risk factors. The risk factors that have been identified are radiation, greater than 100 centigrays of exposure, perhaps some viruses, certainly chemicals such as benzene, toluene, certainly the exposure to drugs such as alkylators, which are used in the treatment of other malignancies, arsenicals, phenylbutazone, and chloramphenicol. The alkylators are especially worrisome in that we're seeing an increased risk of, or an increased incidence of AML in women that have been treated for their breast cancer with adjuvant chemotherapy that included alkylators. We also see an increased risk of AML in young adults that were treated as children for solid malignancies using alkylating agents. Hereditary AML does exist in Bloom syndrome. A typical Bloom syndrome patient is Jewish, with short stature, thin, has delicate features, and may have cutaneous abnormalities. Fanconi's anemia is a hereditary anemia. It has an unusual genotype in that these patients have absent radii, have hypoplastic thumbs, and may have microcephaly. Fanconi's anemia has been linked to AML. Trisomy 21 or Down syndrome is a predisposing factor to the development of both AML and ALL, but with AML being more common. If one patient or if one sibling has AML or ALL, the other sibling has at least a 5 times risk. If they're monozygotic twins, there's a 25% chance if one twin has leukemia, the other one will develop. This has implications when we move some of these patients towards stem cell transplantation, and that our usual preferred donor is a sibling, or if they have an identical twin, we'd use the identical twin as a donor. The presenting physical findings of a patient with an acute leukemia are generally pretty nonspecific. It's usually they feel tired, they may have a fever, or they have an unexplained infection that won't go away. Sometimes they'll have weight loss, headaches, or a cranial nerve palsy that would indicate a meningeal involvement with their leukemia, or some have obstipation. Especially with acute lymphoblastic leukemia, they may complain of abdominal fullness, which represents splenomegaly, or diffuse bone pain. Physical findings are those of pallor, some petechiae specifically around the ankles or in the mouth, purpura. They may have sternal pain or lymphadenopathy or hepatosplenomegaly. These are all much more common in the patient with ALL as opposed to AML. Meningismus, which is a stiff neck representing some inflammation of the meninges, is more common with ALL than with AML. An examination of the fundus might reveal flame hemorrhages, which represent which are a reflection of the thrombocytopenia. Some subtypes of acute myelogenous leukemia, such as M5, which is a monocytic acute myelogenous leukemia, has a tendency to infiltrate extranodal areas, specifically the gingiva, and patients may have unexplained gingival hyperplasia. Patients may present with bleeding. The most critical to diagnose is diffuse intravascular coagulation, or DIC. It is most common with the promyelocytic type of AML, which is also known as M3 and has the translocation of 15-17 chromosomes. The laboratory evaluation of a patient with acute leukemia requires a bone marrow exam that has greater than 20% blast in the marrow. There's also cytogenetics, which looks at the actual chromosomes to see if they're translocations. Special stains such as terminal transferase or TDT or peroxidase. These are stains that are done on cells and then looked at under the microscope. A CBC needs to be done. If there's an anemia present, it's usually hypoproliferative, normochromic, and normocytic. Most patients will have a leukocytosis. However, a quarter of them will have leukopenic findings. 15% will have a normal CBC, and about 90% of patients will have a thrombocytopenia. That's why so many of them present with petechiae or bleeding problems. Chemistries that need to be obtained at diagnosis include potassium, creatinine, uric acid, calcium, phosphate, magnesium, hepatocellular assays such as liver function test, also an LDH, and look at the coagulation panel to detect any diffuse intravascular coagulation. Most of these studies are necessary to anticipate what is called the tumor lysis syndrome, which occurs when chemotherapy is given, causing further metabolic derangements that can lead to renal failure. Also, in the case of acute lymphoblastic leukemia, the spinal tap to obtain cerebrovascular fluid will have to be checked, even if the patient is asymptomatic, because central nervous system involvement with ALL is very common. It is less common with AML, so a spinal tap is not required unless the patient has symptoms such as meningismus or cranial nerve palsies. Also, an evaluation for the cause of the fever, if there is one, should be made, or looking for abscesses, as these will probably need to be treated before definitive treatment for the leukemia is started. This is a laundry list of things that need to be done in a leukemic patient for their initial workup. Of course, a history and physical needs to be obtained. We've talked a little bit about the laboratory that needs to be obtained, such as a CBC and coagulations, bone marrow biopsy. The bone marrow biopsy is necessary to look at morphology, cytochemistry to look for, that's what they do with the special stains, immunophenotyping, which is flow cytometry to look at specific molecules on the membranes to further classify the leukemia, cytogenetics, which looks for the translocations and deletions of different chromosomes. HLA typing may be done of the family, or a search of the unrelated donor registries, such as the National Marrow Donor Program, may be started early in the course if the patient appears to be a transplant candidate. A cardiac scan to monitor for the efficiency of the ejection fraction is necessary because the acute leukemias all require therapy with anthracyclines, which may be cardiac toxic. Central venous catheter needs to be inserted to allow frequent blood draws, the administration of transfusions, and the administration of chemotherapy without the starting of numerous peripheral IVs. It has become clear over the last few years that the presence of a specific mutation called the FLT3 is a bad prognostic sign, so that needs to be checked at diagnosis, as there are now new medications that have some effect on the FLT3 mutation and will improve their prognosis somewhat. And it's important to determine that early in the course of the disease, because the medicine needs to be started early in the course of therapy. There is a classification of acute myelogenous leukemia called the FAB classifications, which stands for French, American, and British, which is a consortium that determined these different subtypes. These, since they're myeloid malignancies, they all start with an M and then they have a different number. These have been replaced somewhat by the development of cytogenetics, which are reflected by in some of these subtypes on this slide, such as the inversion 3 chromosome, the translocation 821 and M2, and most importantly, the translocation 1517 seen in M3 or acute promyelocytic leukemia. As I mentioned on an earlier slide, all the cell types in the myeloid line could develop a malignancy, and this is reflected in the FAB classifications. You can see we have myelomonocytic, monocytic, erythroid, and megakaryoblastic leukemias. While AML is a grave disease, there are some findings that give a better prognosis than others. If the white count at diagnosis is less than 39,000, if the LDH level is normal, or if it's an M2 type, which has a translocation of 821, if it has M4 with eosinophils, if it has the cytogenetics of an inversion 16, or if it's acute promyelocytic leukemia with a translocation of 1517. Those are all good prognostic findings. Another bad prognostic finding that is not on this slide is the FLT3 mutation, as previously mentioned. This slide is inserted to give you some idea of the impact of these good or bad prognostic features. You can look at patients that had a favorable outcome in their survival at 5 years with acute myelogenous leukemia is approximately 55%. However, patients have unfavorable prognostic findings, their survival at 5 years is only 11%. The treatment of leukemia has its special language, and that we talk about the induction phase, the consolidation phase, the maintenance phase, and post-remission therapy. I'll talk a little bit about this so that at least you can sound like you know what you're talking about when you are at cocktail parties. The initial treatment of leukemias is referred to as induction, meaning induction of a remission. This is a list of the most commonly used drugs in AML, which is donomycin, which is an anthracycline, cytarabine, which is a antimetabolite. Idarubicin is also a anthracycline, And sometimes if we're not able to give an anthracycline because of cardiac disease, we may use a higher dose of the Ara-C. Consolidation could be read as consolidation of the remission, and frequently consolidation therapy is the readministration of the same drugs in perhaps a different dose than were used for the induction of the remission. Let's talk about acute promyelocytic leukemia, which really is a horse of a different color in the way that it's diagnosed, its treatment, and some of its complications. If we go back to the FAB classification, it is an M3, but most importantly, it has a translocation of chromosomes 15 and 17. This on the chromosome 17 is where the retinoic acid receptor gene is, which controls maturation of myeloid cells. So, the treatment of this disease is with vitamins, all trans retinoic acid, plus an anthracycline. Remissions can be obtained with all trans retinoic acid by itself. However, the anthracycline is required to have a sustained remission and a very good chance of being cured. These treatments do not work as fast as chemotherapy agents do in other acute myelogenous leukemia types, in that the marrow is only reassessed a month or so after the starting of therapy, as opposed to 2 weeks when seen with other AMLs. Let's turn our attention away from the liquid blood cancers, or the bad blood, to the pones and rhizons as represented by the lymphoma. Thomas Hodgkins described the original lymphoma in 1832, and about 30 years later this was named after him, called Hodgkin's disease. Now, as things frequently happen, what he described was probably not what we now describe as Hodgkin's lymphoma. It probably had some infectious disease as well as non-Hodgkin's lymphoma, but he's credited with the description of the first types of these malignancies of the lymph glands. So Dr. Hodgkins was a pretty ambitious young man in that he described these disorders, quote, on some morbid appearances of the absorbent glands and spleen, end quote, while he was a medical student in 1832. Now, further definition of what exactly Hodgkin's disease or Hodgkin's lymphoma is was made by Carl Sternberg and Dorothy Reed in 1898 and 1902, and they described the Reed-Sternberg cell, which is seen with classic Hodgkin's disease. This also helped differentiate non-Hodgkin's lymphoma from Hodgkin's lymphoma. Non-Hodgkin's lymphomas are much more common than Hodgkin's disease. This is seen in this pie graph where the non-Hodgkin's part of the Pac-Man is eating the much smaller Hodgkin's lymphoma. Within the non-Hodgkin's classification, there's the diffuse large B-cell lymphoma, follicular lymphoma, and then a panoply of other non-Hodgkin's lymphoma, of which 85% of all non-Hodgkin's lymphomas are of B-cell lineage. Hodgkin's disease is uncommon. Only 0.7% of all new cases of cancer are Hodgkin's disease, which gives it an incidence of only 3 cases per 100,000 people. So that makes there about 7,500 new cases per year in the United States, with a slight predominance of men over women. Interestingly, it's less common in African Americans at 2.3 per 100,000 versus the 3 cases per 100,000 in the Caucasian population. There does seem to be a slight familial predisposition that is poorly understood. The epidemiology and etiology of Hodgkin's disease is interesting in that there's an age-related bimodal incidence in at least in developed countries, with the first peak being in the 3rd decade of life, meaning young adulthood, and then a second peak occurring after the age of 50. It's thought that the Epstein-Barr virus exposure may contribute to this incidence of childhood Hodgkin's lymphoma, especially in underdeveloped countries. There does seem to be a presence of the EBV genes and clones within the malignancy in about 40% of patients with Hodgkin's disease, which may or may not be a causative effect of Hodgkin's disease. Of course, not everybody that has EBV exposure will develop a malignancy. So what other factors are involved remains unclear. Well, remember Doctors Reed and Sternberg. This is the cell that they described that has also been described as a cell with owl eyes. It's binucleated and larger than the surrounding cells in the lymph node. It's a germinal center B cell. This is the malignant cell of Hodgkin's disease. The cells surrounding it are polyclonal, meaning they are not part of the malignancy, and they seem to be reactive lymphoid cells reacting to the presence of the malignancy. Not all Hodgkin's disease will have Reed-Sternberg cells, but the ones described as classic Hodgkin's disease usually do. I previously mentioned classical Hodgkin's lymphomas, and those are subtypes seen as nodular sclerosis, mixed cellularity, lymphocyte-rich, lymphocyte-depleted, or lymphocyte not depleted Hodgkin's disease. These are all defined by their appearance under light microscopy. There's another type of Hodgkin's lymphoma called nodular lymphocyte predominant Hodgkin's disease that may not behave as other Hodgkin's disease, and in some classifications is handled separately. As you know from your anatomy class, we have lymph nodes all over our body, and any of these can be involved with either Hodgkin's lymphoma or non-Hodgkin's lymphoma. Both Hodgkin's disease and non-Hodgkin's lymphoma are defined by staging, and the same staging is used for both types of lymphoma. Stage 1 disease is a single lymph node involved with the disease. Stage 2 is 2 sites of lymph nodes involved with disease, but they both have to be on the same side of the diaphragm. Stage 3 is disease on both sides of the diaphragm. It may still just be 2 sites, but because they're on opposite sides of the diaphragm, that makes it a stage 3. Stage 4 denotes widespread disease that involves multiple organs, and extranodal involvement, such as the liver or bone marrow, would make a patient have stage 4 disease. Hodgkin's disease is always treated with curative intent and utilizes radiation or chemotherapy, or in some cases both. Early stage disease, such as 1 and 2, may just require radiation treatment. The presence of B symptoms, which are weight loss, fever, perhaps pruritus, may necessitate the use of chemotherapy with the radiation. Stages 3 and 4 are generally treated with chemotherapy alone. The cure rate of these therapies exceeds 80%. Non-Hodgkin's lymphoma, similar but different than Hodgkin's disease. Here we are back at this slide, again to orient you that we're back up here on the B cell differentiation channel in the germinal center, looking at B cells, which are most of the non-Hodgkin's lymphoma are B cell malignancies. However, there are the uncommon T lymphocyte non-Hodgkin's lymphomas. These patients frequently present with lymphadenopathy, as seen in this man that has axillary lymphadenopathy. A rule of thumb is that if someone has a persistent lymph node larger than 1 centimeter, it needs to be biopsied. By persistent, that means they're longer than 2 or 3 weeks. Almost all of these patients have received a course of non-specific antibiotics to see if the lymphadenopathy goes away. But again, the 1 centimeter seems to be a good criteria to further pursue a diagnosis. The presenting signs and symptoms of non-Hodgkin's lymphoma are enlarged lymph nodes, or there could be some general nonspecific symptoms such as weight loss, fever, night sweats, fatigue, and the rare patient that has pruritus. But less than 20% of patients have general symptoms at onset. Most people will present usually with the enlarged lymph nodes. The risk factors of developing non-Hodgkin's lymphoma are not especially well defined. Most causes of NHL are unknown. There may be an inherited familial component, but it accounts for a small percentage of patients. There are some environmental factors that have been clearly implicated, such as herbicides. High-dose radiation may also cause NHL. Immunosuppression, such as patients that are post-organ transplantation and are on prolonged immunosuppression, have an increased risk of non-Hodgkin's lymphoma, as do individuals that have HIV infection. In fact, the development of a lymphoma is an AIDS-defining event. Viral and bacterial infections may cause some non-Hodgkin's lymphoma, such as HTLV1, Epstein-Barr virus, as previously mentioned for other problems, and H. pylori bacteria. H. pylori is interesting in that it can cause a very superficial lymphoma of the GI tract that is treated with antibiotics rather than chemotherapy. Typical of other hematologic malignancies, the incidence of non-Hodgkin's lymphoma tends to increase with age, again with the increase occurring in the 5th or 6th decade of life. The initial diagnosis and evaluation of non-Hodgkin's lymphoma can follow what is seen on this slide. A fine needle aspiration can be done, however, an FNA fails to give information regarding whether the tissue is follicular or diffuse, and that can only be obtained with an excisional or incisional biopsy of lymph node tissue. A bone marrow exam usually is necessary to completely stage the patient to see if they have involvement of their marrow. A lumbar puncture is usually not needed unless it's a highly aggressive lymphoma such as Burkitt's or they have CNS symptoms. Laboratory tests are fairly straightforward with a CBC, complete a metabolic profile, and an LDH. Also, a uric acid should be obtained to make sure they're not at risk for tumor lysis syndrome. Imaging studies will almost always include either computed tomography or CAT scanning. Magnetic resonant image may be needed in some specific circumstances, and PET scanning has moved to the forefront of complete staging. I put this slide in to show the diversity of the types of non-Hodgkin's lymphoma, also to see if any of you that are still awake might fall asleep in reading the classifications of non-Hodgkin's lymphoma. I know it does that to me. The takeaway from this slide should be that there are really 3 different groups of non-Hodgkin's lymphoma, and those are indolent, aggressive, and very aggressive. If you'll notice on the indolent side, we're still counting chronic lymphocytic leukemia and counting it as a small lymphocytic lymphoma because they have similar behavior as indolent disease. Now, interestingly, the aggressive and very aggressive tumors are being defined as that because of their untreated biology. However, they are the ones that are most likely to be cured, even though they have the aggressive and very aggressive classifications. Of special interest is the Burkitt's lymphoma, seen under the very aggressive classifications. That particular type of non-Hodgkin's lymphoma is the fastest growing tumor known, with a doubling time of almost 48 hours. But it is very curable with current therapy. Not all types of non-Hodgkin's lymphoma are treated the same way. Treatment is determined by the grade of lymphoma, which measures the growth rate and identifies aggressiveness, as well as the cell type. The cell types were on that previous slide, such as diffuse large B-cell lymphoma, follicular lymphoma, mantle cell, etc. There are more than 40 subtypes of lymphoma, which make it a very confusing field. Also, the stage of disease. This gets back to some of our indolent lymphomas that aren't treated, they're watched. Again, keeping in mind like the follicular lymphomas and the chronic lymphocytic or small cell lymphomas may take a wait and watch approach initially. How these different subtypes of non-Hodgkin's lymphoma respond to therapy is determined by which classification they reside. Such as the indolent or low-grade lymphomas, they progress slowly, but they do respond well to initial treatment and frequently go into remission. However, they will almost always relapse. But then even the relapse responds to an additional treatment. This has a pattern that each remission lasts about half as long as the previous remission until it becomes a refractory disease and no longer responds to treatment. The aggressive lymphomas, which include the intermediate grade and high grade lymphoma, have rapid progression. However, as previously mentioned, they do have a fairly decent chance of being cured, in excess of 50% and sometimes as much as 80 to 90%, depending upon the cell type and its stage. The treatment of non-Hodgkin's lymphoma could involve the use of radiation, especially in early stage indolent lymphomas, chemotherapy, which is used for advanced stages of indolent, intermediate, and high-grade lymphomas, but is the cornerstone of treatment in aggressive or highly aggressive lymphomas. And in some cases, chemoradiation is used, which is both. If a patient that has Hodgkin's disease, it is called bulky disease, meaning that it involves a large portion of their thorax. There may be radiation given to that in addition to the chemotherapy. There's another type of radiation that is given which may use monoclonal antibodies that are linked with a radioactive isotope. The antibody is directed against certain molecules on the malignancy and delivers the radiation directly to the tumor. This is sometimes referred to as, quote, letter bomb therapy, end quote. Follicular lymphoma is the most common type of indolent lymphoma, and it's usually widespread at presentation, but is causing minimal amount of symptoms and may actually be asymptomatic. It's usually not curable. However, there may be some exceptions, especially in early stage disease. It's associated with a BCL2 gene rearrangements that is represented by a translocation of chromosomes 14 and 18. It is a germinal center B cell. Follicular lymphomas are one of the malignancies that's similar to CLL and small cell lymphoma, and that treatment can be deferred if it's asymptomatic, and the wait and watch approach can be employed. If treatment is given, there are several chemotherapy options available that march across the scale of intensity. Some have very few side effects, and some are relatively toxic that would be, and those treatments would be saved until later relapse. The median survival of follicular lymphomas is generally measured in years. However, they will eventually cause significant morbidity and mortality. If the tempo of a patient's follicular lymphoma suddenly changes, it may be that there's been transformation to a more aggressive lymphoma, such as a diffuse large B-cell lymphoma, and this will certainly require a change in therapeutic approach. Diffuse large B-cell lymphoma is the most common type of the aggressive lymphomas, and it is usually symptomatic on presentation, and extranodal involvement may be common. It's a germinal center B-cell, and treatment is always offered at the time of diagnosis because it will grow fast. It is curable in at least 40%, and with newer treatments, this can approach 60 to 70%. So this slide is an attempt to put together the non-Hodgkin's lymphomas and Hodgkin's lymphomas as far as their prognosis and curability. We start here with the non-Hodgkin's lymphoma indolent. The survival is usually in years. Even if untreated, they're generally not curable, but very treatable, and that treatment is deferred until they become symptomatic. Aggressive and very aggressive non-Hodgkin's lymphoma have survival of months to weeks if untreated. However, if treated, they're curable in many of the cases, and treatment is always offered up front. Hodgkin's disease, all types, remember the classic Hodgkin's disease with the different subclassifications, those patients would survive for months to years depending upon the subtype of Hodgkin's disease, but they are almost always curable, and treatment is always offered. Okay, take a deep breath. This is the last hematologic malignancy we're going to talk about today, multiple myeloma. Here's that slide again. Again, to orient you, we're out here talking about, on the upper row, multiple myeloma. The malignant cell is a plasma cell. So what do plasma cells do in their normal life is they make immunoglobulins. But they have gone to the dark side, and now they're going to cause multiple myeloma. This is a bone marrow biopsy of a patient with multiple myeloma. The monotony is caused by plasma cells. There'll be a blue cell with a deep red-purple nucleus. It's eccentric, and off to the side of the eccentric nucleus is what's called some pallor. That pallor is caused by the stockpiling of the immunoglobulins that will be secreted by the plasma cells. It is not uncommon for multiple myeloma to cause pathological bone fractures, as seen as this humerus fracture. You can see that in the shaft of the humerus there is some alternating dark and white areas. Those dark areas are myelomatous involvement of the marrow. You can also see that the cortex is thinned along these ways, which eventually can lead to a fracture. This obviously is a lateral view of the skull with what's known classically as a salt and pepper appearance. You can also view it as a moonscape with the craters being myelomatous involvement of the skull. This x-ray of the femur shows a lytic lesion in the shaft that shows cortical thinning and would be a candidate for rotting before the fracture occurred, since it is at high risk of fracture at this time. The nomenclature of plasma cell disorders can be confusing in that we talk about multiple myeloma, smoldering myeloma, solitary plasmacytomas of the bone, monoclonal gammopathy of unknown significance, amyloid, and Waldenstrom's macroglobulinemia. All of these fall under the large classification of plasma cell dyscrasias and have much in common, but also have some differences. Solitary plasmacytoma is just one area of increased malignant plasma cells, and that may be treated with just radiation and not require systemic therapy. Monoclonal gammopathy of unknown significance is thought to be the pre-malignant condition that leads to multiple myeloma, and would then follow down a cascade of becoming a smoldering myeloma and then symptomatic myeloma. Amyloid is the deposition of light chains that come from the immunoglobulin. These depositions occur in critical organs such as the heart, liver, and kidneys. And Waldenstrom's is a plasma cell disease that makes IgM immunoglobulin, and it has a different clinical picture than the other plasma cell dyscrasias. Similar to many of the hematologic malignancies, we don't have a firm grasp on what causes multiple myeloma. It doesn't seem to be related to radiation or exposure to solvents, paints, or pesticides. There are not any epidemiologic clusters. There may be related to human herpes virus 8. There's some evidence for and against this. The incidence among African Americans is twice that of Caucasians, and there again there's a male predominance over females. And it does appear to develop from the monoclonal gammopathy of unknown significance. While this slide shows the incidence of multiple myeloma, you'll notice that it is very similar to that seen with the other hematologic malignancies, in that we start seeing the incidence increase around the age of 50 or 60. To say a patient has multiple myeloma, they must reach what are called the CRAB criteria. They should have, or they may have, an elevated calcium, renal disease, anemia, or bone disease. They don't need to have all four of these, but they need to have something involved that's making them symptomatic among these four. There are two staging systems in multiple myeloma. There's the Dury-Salmon staging system and the international staging system. Both of them are used again to give a reflection of tumor mass as well as prognosis. With the Dury-Salmon staging system, it uses the hemoglobin, the serum calcium, whether there are bone lesions by X-ray, whether there is M protein. The M protein is the type of immunoglobulin being produced, M standing for myeloma protein, and whether there's the M protein also found in the urine. The international system uses slightly different parameters, such as the beta-2 microglobulin and the serum albumin, to determine the stage, but both of them give the same sort of information, with an advanced stage being less favorable. This is a summary slide bringing together the criteria that are used to determine either the Dury-Salmon or international staging of the presence of anemia, calcium, bone disease, myeloma or M protein, or the beta-2 microglobulin level. The treatment of multiple myeloma has undergone a revolution over the last few years. While just a few years ago the median survival of multiple myeloma patients was about 3 years, it's now been lengthened to 8 years by the use of many of the drugs listed on this slide. The progress has been so dramatic that 3 years ago, in 1 month, there were 4 different drugs for multiple myeloma introduced. The broad classifications of therapeutic agents include alkylators, which have been around for many, many years, steroids such as prednisone, immunomodulating agents, proteasome inhibitors, the monoclonal antibodies directed against plasma cells, and autologous stem cell transplantation. Autologous stem cell transplantation is not curative, however, its goal is to give a prolonged remission. So by the use of all of these, patients with myeloma now have a much brighter future than they used to just a few years ago. This is the end of the slides that I have. However, there is a therapy that I think you should be aware of called CAR T-cell therapy, chimeric antigen receptor T cells. This is a new technology that had been approved to treat pre-B-cell ALL and diffuse large B-cell lymphomas. It uses a virus to incorporate a receptor into T cells that will then target specific molecules on malignant cells. It is, like I said, now commercially available for pre-B-cell ALL in children and young adults, and diffuse large B-cell lymphomas in adults. It is being investigated to treat multiple myeloma and CLL, and will also go into clinical trials treating other solid malignancies. This is really the harnessing of the immune system to attack a malignancy. Some of these products that are on the market are interesting in that the T cells continue to live, and so they provide a sentry function even after the disease has gone into remission, so that if it tries to come back, there's some memory on the part of the T cells, which then attack it again. So this is something to keep an eye out for as time goes by. I hope you found this presentation helpful and interesting. Thank you.